Welcome to the Radiation Safety and Computed Tomography Virtual Symposium. I'm Tony Seibert from the University of California, Davis Medical Center in Sacramento, California. And today I'm presenting on the topic of imaging special populations and circumstances. The first question to ask is, what is meant by special? Certainly there are populations that require special considerations, such as the pediatric patient as well as the bariatric patient, from one extreme size to the other. Imaging acutely injured trauma patients requires decisions on a scan or not to scan basis. Also challenging is the positioning and imaging of patients that require the use of otherwise unacceptable parameter settings, such as using a large scan field of view for a head examination. Cardiac CT, which made a lot of headlines about 4 to 5 years ago, qualifies as a special population, particularly when it comes to using advanced acquisition technologies to reduce dose. Brain perfusion studies are also an item given the widely published overdose incidents in 2010. Screening CT for patients with a history of smoking is now underway based upon the large national lung screening trial. Regardless of the special group, the underlying principles are to use exam-specific protocols with appropriate adjustments for the case being considered. In some cases, the body part to be imaged is not easily positioned and can require less optimal CT settings with less desirable outcomes. In cardiac CT imaging, high temporal resolution is necessary to image the beating heart. Often, patients must be subjected to drugs in order to keep the heart rate at a level that reduces anatomic blurring, and to use techniques such as cardiac gating with prospective timing that can substantially reduce radiation dose. For perfusion scans, a key consideration is the continual irradiation of a specific volume of the patient, with an increased likelihood of deterministic radiation damage effects on the skin and within the irradiated volume. This requires careful scrutiny of the acquisition techniques. In academic settings, there are many clinical and research studies that require analysis and vetting of the protocols prior to patient recruitment. Currently, for the pediatric population, the Image Gently initiative provides descriptive protocols and optimization methods published on the website to ensure the lowest possible radiation dose commensurate with the diagnostic need. Recommendations include matching the scan field of view with patient size, adjusting the KV, MAS, pitch, collimation, and CT automatic exposure control parameters. Statistical iterative reconstruction methods, when available, can be applied to allow an even lower radiation dose with similar image quality. Use of the fastest gantry rotation speed and in some instances high pitch values are used in lieu of patient anesthesia to reduce patient motion artifacts in the young and uncooperative patient and improve the likelihood of getting a diagnostic CT exam with high throughput. The Image Gently website provides step-by-step instructions to develop CT protocols for children based upon reasonable adult techniques as shown by the example table in this slide. So how can more sensitive organs such as the breast and the pediatric female be better protected? There are many that advocate the use of business shields for the breast and other areas, but this has become a controversial topic. While the shields do reduce dose to the breast by up to 20% or more, their use increases CT artifacts and introduces Hounsfield unit inaccuracies, as shown in the lower left figure, comparing a scan with and without a shield. Also, when the X-ray tube is on the opposite side of the body, useful X-rays exiting the patient are being attenuated by the shield. Another potential complication is with CT automatic exposure control. For scanners that use the localizer to determine AEC settings and MA modulation, the shields must be out of the localizer scan. Otherwise, the scanner will adjust for the presence of the attenuator, making the dose even worse. Alternatives for breast shields are to use lower MA technique settings in the region of the breast, or in some CT scanner models using an organ-based modulation, as shown in the lower right diagram of this slide, which provides an ability to reduce the MA during the section of the scan that directly exposes the breast, and to increase the MA at other times, such that the overall MAS per slice is the same, with the outcome being a lower breast dose with no untoward effect on image quality. Regarding the pediatric body, one caution is the discrepancy between manufacturers when generating CTDlvol estimates. At UC Davis, we encountered an interesting situation for a 15-year-old child with a 25-centimeter effective diameter, displayed above, who had a pre-surgery scan for planning. The posted CTDlvol for the exam was 4.78 milligray. Note that this manufacturer uses the 32 centimeter diameter phantom for this exam. Post-surgery, the patient was scanned with another manufacturer's scanner, and the AEC dose modulation was also used. Note that this manufacturer uses the 16 centimeter diameter phantom for determination of CTDlvol values. The CTDlvol reported for this exam was 17.7 milligray. The patient's mother, requesting dose information, was very upset as to why the second scan was so much higher exposure. Part of the reason was the inclusion of highly attenuating NUS bars as part of the surgical procedure. But 4 times more exposure? After further investigation and timely publication of the AAPM Task Group Report number 204 on size-specific dose estimates, a method to correct for differences between the CTDI calibration phantom diameter and the effective diameter of the patient was used. Published conversion factors were applied to the reported CTDlvol values. For the pre-surgery exam, the indicated CTDlvol was underestimated by a factor of 47% because the patient diameter was much smaller than the phantom diameter. Conversely, for the post-surgery scan, the CTDlvol was overestimated by about 30%. The net result after SSDE correction was SSDE values of 7 milligray for the pre-surgery scan and 12.5 milligray for the post-surgery scan over the pulmonary area where the NUS bars were present, a difference of 1.8 times, and 7.0 milligray versus 7.7 milligray over the areas of the abdomen, a difference of 1.1 times, or essentially the same CTDlvol. The bottom line here is that current ways for reporting CTDlvol metric are prone to error due to constraints of the methodologies used for estimating them, and must be used with caution. Methods for correction, such as the size-specific dose estimate, SSDE, are a good first step. Further investigations are needed for extending the work to DLP, which is the product of the CTDlvol and length of the scan, which will also be affected. Large patients and associated high attenuation make the bariatric population a very challenging subgroup to obtain reasonable image quality. Limitations in output, particularly for older CT scanners, requires an increase in acquisition time, for instance from 0.5 to 1 to 2 seconds, and an increase in kV from 120 to 140 to increase the number of X-rays transmitted through the body. In some contrast studies, the higher kV will reduce the signal due to the iodinated contrast, so a noisier image at 120 kV is often acquired and preferred. When using automatic exposure control, a higher noise index, for instance 35, or a lower effective MAS target quality parameter is used. In terms of CTDlvol, usually the indicated values are overestimates as illustrated in the slide. A size-specific dose estimate yields a value that accounts for the discrepancy in effective biopsy diameter compared to the phantom. A conversion factor of 0.8 results in an SSDE of 28.6 milligray compared to the reported 35.8 milligray. For bariatric patients, many of the dose estimates will be outliers as shown in this exam distribution of calculated effective dose values from a dose software package. Bigger patients will have bigger doses. In the localizer scans on the left, notice the tube current modulation value depicted by the green vertical curve superimposed on the patient localizer scans and an anthropomorphic phantom. The MAS increases as the curve moves to the right in the figure. In this example, the tube current is at the maximum MA value in the thicker parts of the body. The trauma patient population often represents a CT scan from head to toe, almost as an initial triage of patient status for further action, with trauma-specific protocols. For instance, at UC Davis, we require head and neck CT performed in one pass with a protocol that uses a pitch of 0.5 and commensurately low MAS to reconstruct high-quality 2D and 3D reconstructions for facial scans, and with the same data, the standard axial images of the brain are reconstructed in lieu of performing another exam. Trauma protocols in other regions of the body are similarly configured. In terms of limiting patient dose from CT, particularly for the pediatric population, a question of when not to use CT based upon prediction rules is often the question to be answered. Dr. Cooperman and colleagues in a prospective multi-institutional research study published in the Lancet Journal in 2009 demonstrated that the use of prediction rules is very successful in identifying low-risk brain injury situations in which CT can routinely be obviated. This is the extreme no radiation dose example of caring for the patient. Imaging patients that cannot easily be centered in the gantry sometimes requires less than optimal acquisition adjustments. The example shown in this slide is of a patient with severe scoliosis who could not be positioned in the head holder for a head CT scan. In order to acquire the head CT images necessitated a large scanned field of view and reconstruction of the axial slices in an off-axis smaller display field of view. As there were attenuating objects in the head brace outside of the display field of view, image artifacts were introduced into the reconstructed image dataset as shown in the example, axial image. Note that the dose report and the phantom dimension of the 32 centimeter for a head CT was used. Needless to say, the radiologist was not too happy about the images, and the CTDlvol was underestimated. Including a note indicating the issues of the exam would have been an appropriate course of action. The speed and capabilities of modern CT scanners has opened access to a large population of patients with cardiac disease. Diagnostic cardiac CT has multiple uses, from coronary calcification scoring to evaluation of physiological parameters such as ejection fraction and stroke volume, to perfusion studies and anatomic analysis of coronary arteries, among other applications. Implementation of several technological advancements such as tube current modulation, prospective gating, step and shoot modes, higher pitch acquisitions, and iterative reconstruction algorithms has resulted in a significant relative dose reduction of up to 90% and more compared to earlier studies, as reported in a 2011 publication in the Radiology journal. Each of the technology enhancements are covered elsewhere in this virtual symposium. Patients with suspected stroke or transient ischemia are referred to CT for evaluation of perfusion by uptake of contrast in the tissues over time, as shown in the upper right image series, which provides functional images such as cerebral blood flow, cerebral blood volume, and mean transit time. However, because the X-ray tube is positioned at the same location for a continuous period of time, high radiation overdoses can be delivered, as illustrated by a patient with epilation, indicating peak skin doses of 4 to 6 gray. The dose length product metric is not indicative of skin dose, and is also potentially suspect for estimating effective dose through the use of published conversion factors, as only a small volume of the brain is irradiated. One place to start for reasonable protocol parameters is on the American Association of Physicists in Medicine CT protocol site, with suggested technique factors listed by the manufacturer and type of scanner. How does one achieve reduced CT imaging? In terms of screening CT for a high-risk cohort of patients such as smokers, specific protocols to achieve significantly reduced radiation dose are published by the National Lung Screening Trial investigators, with 120 kV, 25 to 50 MAS for a 0.5 second scan, and 2.5 millimeter slice thickness, delivering about 2 to 4 milligray CTDlvol. One can also invoke CT automatic exposure control with a high noise index or a low effective MAS setting that could adjust for patient size interactively. In summary, it is now hopefully clear that there are a large number of special populations that present with unique requirements and considerations for CT imaging, from the large to the small, for imaging anatomy and function. There are also many special circumstances to take into account in order to achieve the necessary image quality at the lowest possible dose, as, for example, the screening chest CT application. Certainly for all procedures, exam-specific CT protocols are a must and require careful analysis and diagnostic need, the patient habitus, the ability to cooperate during a scan, and many other factors as discussed in this presentation. An example of the pitfalls with current dose metrics has been explained and described how misleading the values can be. Finally, getting the CT procedure performed at the right dose with the right image quality and the right protocol, and tracking dose levels and image quality for protocol improvement opportunities is the way to improve safety and care for each patient. Thank you very much for your attention.